Hello, welcome to an Advanced Healthcare Network webinar. My name is Dylan Stickle, and I am an editorial assistant with Advance and the moderator for today's presentation given by Joseph Feldman, MD, FACEP, on VIDAS D-Dimer Exclusion 2, Excluding a Diagnosis of Deep Vein Thrombosis and Pulmonary Embolism in Outpatients with Suspected VTE. This webinar is presented under the sponsorship of bioMérieux Incorporated. Now a little bit about our presenter. Dr. Joseph Feldman has been with Hackensack UMC since 1998, where he is an attending physician and is chairman for the Emergency and Trauma Center at Hackensack and chairman Emergency Medicine at Hackensack UMC, Pascack Valley. Prior to coming to Hackensack UMC, Dr. Feldman was the Assistant Director of Emergency Services at Columbia Presbyterian Medical Center. Dr. Feldman received 2 Bachelor of Science degrees from Stony Brook University prior to attending St. George University School of Medicine, where he obtained his medical doctor degree. He completed his emergency medicine residency at the Brooklyn Hospital Center and is board certified in emergency medicine. Dr. Feldman is a fellow in the American College of Emergency Physicians. At this point, I will turn the presentation over to our speaker.
And I don't know what time zones everyone's in, so either still good morning or good afternoon. It's my pleasure to address you today on this topic that is very timely for emergency medicine. I do have a disclosure in that I am a paid consultant for bioMérieux, and it's really this is not something I normally do, but this is a topic that I really feel positive about because I really do feel it helps us out in emergency medicine in so many ways. At issue in emergency departments today is always to improve the value of care. EDs, and I assume I'm speaking to a lot of people that do emergency medicine, so I'm speaking to an audience that really knows what I'm talking about. EDs are generally overcrowded, and it's really the only way to improve our efficiency is to improve throughput. We're being judged on improving patient satisfaction. And our CFOs are looking for us to eliminate unnecessary testing. And for the leaders in patient safety, we're always looking to eliminate tests that involve radiation. So while being discharged safely with a high rate of diagnostic accuracy and to avoid unnecessary potential harmful medications, at the same time by doing a lower cost per case, this initiative of utilizing D-Dimer with clinical decision rules is a way of fulfilling these goals. At Harvard Health System, they did a study. They asked all their ED providers across their system, both in community hospitals and in academic medical centers, to see what tests and what types of testing and procedures could be altered or eliminated to improve the value of emergency care. They came up with 5 initiatives, most of which many of us currently do in our departments. The first one was to follow the Nexus cervical spine rules to eliminate the unnecessary use of radiating people's cervical spines. The second one is to eliminate the ordering of CT and Doppler ultrasound for DVT, pulmonary embolism, without first risk stratifying them for PE. The third one was to eliminate MRI for lumbar spine patients that are complaining of low back pain without high-risk features, which are usually ruled out by the pneumonic tuna fish. And the fourth was to eliminate CT ordering of brains for people that have had mild traumatic head injury by following the New Orleans criteria or the Canadian CT head rule. And the fifth was to avoid the ordering of PT, PTT unnecessarily for patients who do not have hemorrhage or suspected coagulopathy. Doing a deeper dive into the second initiative that Harvard went into was the use of to get rid of the use of CT and compression ultrasound for people that have been determined to have low or intermediate risk for PE. They wanted to eliminate tests that did not represent high-value care. They wanted to eliminate tests for potential cost savings. They wanted to make sure that if they were going to eliminate a test, that it wouldn't affect quality, and they wanted to make sure that it could easily be implemented in an emergency department. And they found that with the use of a highly sensitive and specific D-dimer like the VIDAS D-dimer, in conjunction with a clinical pretest probability model to exclude DVT and PE in patients suspected of the disease. And they had very positive results in this regard. Now, I don't need to tell people the pathophysiology of DVT and PE, but very, very briefly, a distal DVT originates below the knee in calf veins. And when we look at this population nationally, there's a lot of people still being treated for this disorder, although there's no evidence-based research to show that it affects the mortality and morbidity. If that clot migrates into the proximal veins, then these DVTs are called proximal DVTs. If the proximal DVT propagates, it carries a very high risk for embolization and cardiovascular instability, and this is what causes all the unexplained deaths when it comes to VTE, or venous thromboembolism. So why is this important, and why are we discussing it today? Well, VTE is really the silent killer, and it's a major public issue. PE is a commonly misdiagnosis in the emergency department, and or a delayed diagnosis. And there are multiple risk factors that have increased over the years. One is age. Our population is getting older. People are living longer that might be more immobilized, which is a risk factor for developing DVTs and PEs. A lot more patients are living through their cancer, and cancer is a thrombogenic type of disorder. A lot more people are having surgery, and unfortunately, the BMIs in our country have steadily risen, and a lot more people are obese. And a lot of people with these unexplained PEs, or people having unexplained cardiac deaths, we're finding out are more and more have these congenital coagulopathies with Leiden-5 and protein S deficiencies, and there are a lot more people on hormones for a sorted sundry number of reasons. There's a very high incidence that increases with age for people suffering from VTE, as you can see from these statistics, that in the general population is usually 2 patients per 1,000. In children, it's 1 patient per 10,000. But as we get older, you see that it dramatically increases to 1 per 100 in the elderly. And unfortunately, these PEs have a rate of high mortality, where if we look at the amount of VTEs there are in this country, it's the second most frequent cause of cardiovascular death. There's approximately 850,000 VTE-related deaths per year in the U.S. and the EU. And there is a high rate of morbidity because a lot of patients that have DVTs, proximal DVTs and PEs, have them in a recurrent basis. And all of this ends up being a very high economic burden, where it is estimated that it costs between $2 and $10 billion of annual healthcare costs in the United States. So it's a big problem with a lot of risk, and unfortunately, if it's missed, it is also associated with with death. But why is this a diagnostic challenge? Well, with the onset of spiral CT, we are picking up a lot more, and a lot of people in emergency departments now that we do ultrasound in the ER, we're picking up a lot more DVTs and PEs that we never really suspected before. And it used to be the old adage, if you don't have a QT3 on an EKG, that would be the screening tool for PE, or if a person was have already evolved into a PE, being hypoxemic. But now what we're finding is there's a lot of patients that their symptoms are often nonspecific. They often don't have hemoptysis, don't have hypoxemia. In fact, the overwhelming majority of patients that come in with VTE don't have those classical symptoms. But the diagnostic dilemma is that there's a lot of patients coming in with nonspecific symptoms and risk factors, but there's a very low prevalence of VTE in suspected outpatients, especially those in emergency departments. Only about 20 to 25% of suspected VTE patients actually have a thrombosis. So therefore, about 75% or 80%, between 75 or 80% of imaging procedures are negative, and therefore, if we can come up with a good diagnostic and protocol strategy, a lot of that testing becomes totally unnecessary. And there are disadvantages of imaging everyone that comes in with these symptoms. And what are those disadvantages? Well, unnecessary radiation exposure, high costs associated with it. It adds to the throughput of our patients, and it requires expertise in the way of reading these CTs, because the most ED docs aren't well versed in reading small PEs on a spiral CT. And these tests are invasive, whether it comes from infiltrating an IV or whether it comes from damage it can cause to the kidneys. So advanced imaging is diagnosing more and more DVTs and PEs, but not all of them need to be treated. The evidence for this is that there's an abundant overdiagnosis and overtreatment, finding clinically unimportant emboli ever since there has been this introduction of the spiral CT or CT pulmonary angiography. Overtreatment of insignificant distal PEs and below-the-knee DVTs has been shown to show no increase or decrease in morbidity or mortality. So by treating these insignificant DVTs, we haven't seen any decrease in untoward effects in mortality. And in fact, overtreatment is often coupled with an increased complication of anticoagulation. So there's this performance gap, and we really do need to follow evidence-based guidelines. There is abundant evidence of overuse of imaging in the United States due to the poor adherence of these guidelines. There have been multiple prospective observational studies between 2004 and 2007 in 11 EDs in the United States. But we have seen this explosion of the use of CT for the diagnosis of PE that has increased tenfold from 2000 to 2005 with minimal change in the mortality. 1/3 of all the imaging procedures of suspected DVT and PE are categorized as avoidable if patients are stratified as having a low or intermediate risk and have a negative D-dimer based on the National Quality Forum measures. So we've got to start thinking, or should I say rethinking as a specialty, about DVT and PE, that less is actually more. And in fact, you will get a lot more benefit by doing less and following the evidence-based guidelines regarding the workup of PE. So what is the risk-benefit ratio? Well, we do know that based on whatever protocol is followed for high risk or intermediate or low risk, to make a final diagnosis still will require objective testing by imaging, either by compressive ultrasound or by a spiral CT. But there's this problem again, that there's this low prevalence of only about 20% in suspected ER outpatients. What's the risk of radiation exposure? Well, there is a cancer risk, and this has been well studied, that 1 in 270 women who underwent a spiral CT at age 40 will develop lung cancer at some point in their lives from that CT, and this risk is doubled in patients that are 20 or over. So when the D-dimer is positive, you still have to obtain that diagnostic testing either by one of these two tests. And the problem in our society now is that people aren't following these guidelines, and that a lot of people are getting this radiation exposure. Another risk is major bleeding, especially when we're treating false positive or not significant DVT PEs. Most people that are labeled with this diagnosis are on anticoagulation for 6 months, and there's in all comers is a risk of major bleeding that's 3%. So in my mind, anticoagulation for an insignificant PE or DVT in the elderly is nothing but a subdural waiting to happen with an accidental slip and fall. What effect risk is there to the kidneys? Well, that's something called contrast-induced nephrotoxicity. The incidence of contrast-induced nephropathy, or CIN, following a spiral CT for PE in the emergency department, they've done Mitchell has done a large series and found that there is a bump in pre and post creatinine function testing. The incidence of laboratory-defined CIN was found to be 11% of CIN and 1% of overt renal failure. CIN is defined as a 25% rise in creatinine. So how many of our patients do we have that are diabetic, that are coming diabetic with cancer, or just diabetic alone, that are coming in with risk factors that we need to work up, but end up having renal function problems at the end of the day because they received a CT that they didn't necessarily need to get. The benefit of getting testing in any way, shape, or form, whether we follow the evidence-based guidelines or going directly to testing, is that we are preventing fatal PEs due to misdiagnosis. And this is extremely important because of the M&M statistics that I cited previously. So what is the solution? The solution is to follow a rapid, low-cost, active, and reproducible protocol. Our goal here is to identify low and intermediate risk patients in conjunction with a D-dimer. The identification of a low and intermediate risk patient is done via clinical prediction rules. The use of a non-invasive test has to be done with a high sensitivity and specificity, and that is usually coupled with a D-dimer, and the only one that I know that has that amount of sensitivity and specificity is the VIDAS D-dimer. If this guideline is followed, will result in patients being able to be safely discharged without having an undiagnosed VTE and avoiding harm from invasive testing and potentially harmful treatment. So if it looks like a duck and it talks like a duck, it's probably a duck. And there's many, a seasoned ER doctor doesn't necessarily have to follow or memorize a clinical prediction rule because once you obtain a good history and do a physical, you get a good gestalt feeling about this patient that this person probably has a PE or might have a PE. And so, but there are plenty of clinical decision rules that can be followed. There are several of them that integrate multiple clinical factors. Some of them even overlap. They're the Wells criteria, the revised Geneva scoring, and they take into account risk factors that the patient has, signs and symptoms that the patient has, and then again, your clinical judgment. Obviously, if someone comes in with an obvious likelihood of an alternate diagnosis, you're not going to necessarily be pursuing a VTE in these patients, but you're going to be hedging more toward that alternate diagnosis. These clinical prediction rules are structured in a way to predict risk of having a DVT PE by doing a pretest probability. The pretest probability in conjunction with the clinical prediction rules will guide the diagnostic workup. The PE and that diagnostic workup will stratify patients into 3 buckets: those with low risk, those with intermediate risk, and those with high risk. The most well-known one is Wells criteria, and you can see that some of the points I put here are highlighted in red because I really call those Joe's criteria, which are mine. And that comes from my gestalt from working in emergency medicine for a long time. The number one on the hit parade is active cancer, either treatment or ongoing within the previous 6 months, or palliative treatment, and it's a point system, and we start adding up points based on if the patient has any of these criteria. If the patient is paralyzed or has paresis, a stroke victim, has been in a cast because of a fracture of the lower extremities, or have had a prolonged trip in an airplane or a bus or a train, it's been found that that particular sitting position actually is thrombogenic. That also will give you a point. If the person is recently bedridden for 3 days or have had major surgery within the past 12 weeks requiring general or regional anesthesia, that will give you a point. If the person has a previous history of a DVT or PE, because as I alluded to in a previous slide, there's morbidity to this disease because they're usually, a lot of times they are recurrent. This will also raise your suspicion and give you another point. And then if there are localized symptoms to the lower extremity for DVT, this is the Wells criteria specifically for DVT. If there's tenderness along the distribution of the deep vein system, if there's one leg that's swollen, if there's calf swelling larger than the asymptomatic side, if there's pitting edema to the symptomatic side, or if there's collateral superficial veins that are non-varicose veins, that will also give you a point. But you could also see that you could have minus points taken away if you really, through your gestalt or a physical exam or history, feel there's an alternate diagnosis. At least as likely as a DVT, you would eliminate 2 points. I added in Joe's criteria family history of DVT PE. I usually take that history. Have people drop dead in your family suddenly, any young people? And if you start doing their workup, you find out they have these congenital coagulopathies, and you start ordering more blood work to find out if they're a victim of that. And I've also added taking estrogen or hormonal therapy, since so many men with prostate cancer women in general are taking a lot of exogenous hormone. The Wells criteria for PE are slightly different. Those take into account a previous DVT or PE. Again, there's the surgery and bedridden component for 3 days during the past 4 weeks. If the person has active treatment for cancer within the past 6 months or palliative treatment, if the patient has hemoptysis, if they're tachycardic, if they have clinical signs of a DVT. And here we even take more points away for an alternate diagnosis. Less likely, you would actually give that is equivalent to 3 extra points. The issue here is that obviously if they have a PE, the PE has already happened, but the likelihood, and they've survived that PE if they're not hypoxemic at that point, but the likelihood is they will have a showering of PEs and a bigger and more fatal one might be coming. So after you do your Wells criteria, you start adding up the points to see if there is a predictive value. The Wells criteria for low is 0, for DVT is 0, for PE is 0 to 1, and intermediate risk is 1 to 2, for PE is 2 to 6. And if you have greater than 3 points, you're at a high risk for a DVT. And if you have greater than 6 points in the Wells criteria for PE, it puts you into a high risk as well. My department, we have the largest emergency medicine residency in the state of New Jersey, so the residents keep me on my toes and keep me very academic. And the PERC pulmonary embolism rule-out is something that's commonly used in academic centers now. The PERC was established in 2004 as another type of clinical decision-making rule, and it's a 8-factor decision rule to support the decision not to order a CT in patients of whom the clinician has already had a low clinical suspicion for PE based on either a Gestalt impression or that the patient is low or intermediate. This reduces the probability of PE to below 2% of low-risk patients of suspected PE. And all these questions have to be answered no. So to go through the 8, is the patient, I hate to put myself in this category of being old, but 49 years of age or older, if their person is tachycardic, if the person is hypoxemic, if the person has hemoptysis, if the person is on exogenous estrogen, if the patient has a past medical history of a thromboembolism in the past, and if the patient has had any recent surgery or trauma requiring endotracheal intubation or hospitalization within the last 4 weeks, or did the patient have unilateral leg swelling. If the patient rules out in this situation, some clinicians might say they don't even need a DIMER because it falls into the realm of the not always 100% sensitivity, but it always gives me reassurance when for a patient with lower intermediate risk when I have a negative D-dimer, because my Gestalt might be off, or your history taking might not be totally accurate, and not everyone's body reads the textbook. So the first step is to make sure that the patient is stratified into high, intermediate, or low risk. Then the second step would be to do a D-dimer to do an exclusion test on that patient if they're only if you found them to be in low or intermediate risk. So we all know that D-dimers are a marker of clot formation in the circulation, that acute thromboembolism increases the plasma level due to the natural lysis of larger obstructing clots. Now, a high sensitivity for a thromboembolism, that's the strong point of the D-dimer. Patients with a D-dimer below the predefined cutoff are very unlikely to have a DVT or PE. So that is truly an exclusion test. And the way I always tell residents to remember the difference between sensitivity and specificity is that sensitivity has an N in it, which means that the test was negative and that the patient does not have the disease. But you also want to make sure that there's a high specificity, which means which specificity has a P in it, which means positive. And this isn't suitable necessarily for a rule-in test. Just because the D-dimer is positive, we all know that there are other medical conditions that can cause a D-dimer to be elevated in a variety of conditions with activation of the coagulation cascade, something we all had to memorize in medical school, and maybe when we're recertifying for our boards, but we all want to quickly forget or do forget after the test is over. So the other medical conditions that can cause an elevated D-dimer are infection, inflammation, cancer, surgery, trauma, DIC, either a woman that's pregnant or that's delivering. And if there's a reason for the patient to have a clot for another reason, imaging or compression ultrasound should just be immediately gone to. This is, and not to get the D-dimer at all. So in my mind, this is part of the clinical decision making, that when you're stratifying patients, if you've seen a patient with a bunch of these risk factors that put them into a high-risk patients aren't successfully excluded by this protocol. So if you find a patient in high risk, just go immediately to your Doppler and or CT and not do the D-dimer, because that will just be adding cost per case. But in patients with low or intermediate risk, you should be avoiding the D-dimer. You should be avoiding the invasive testing and going through the evidence-based protocol. So not only is a D-dimer is not a D-dimer is not a D-dimer. There are plenty of D-dimers, and when I first got to Hackensack, we had the run-of-the-mill D-dimer that our obstetricians were using, and using it a lot for patients that go into DIC. When I started investigating what type of D-dimer we had, I realized that I couldn't advance this protocol unless we had our laboratory switch to the VIDAS D-dimer that had a high sensitivity and specificity. There is this inverse relationship between sensitivity and specificity in DVT PE, that the quantitative assays offer the highest sensitivity, and that's the VIDAS D-dimer has the highest sensitivity because it's enzyme-linked fluorescent assay. High sensitivity is required for a safe VTE rule-out. Specificity determines the clinical utility. In other words, a proportion of patients that can be excluded. Specificity should not be too low to minimize the number of false positives that do require the testing itself. When we look at this graph, I'm pointing, the green is the VIDAS D-dimer, and then there are other assays that are not as sensitive. The VIDAS D-dimer that has a 98%, has a 99% sensitivity or 98% negative predictive value. You want to, there is an organization that runs clinical laboratories called the Clinical and Laboratory Standards Institute, and they set this safety limit that you need this 98% negative predictive value. So the Institute recommends requirements for the D-dimer assay for thromboembolism exclusion. You need to have a clinical sensitivity of greater than 97% for safe exclusion, or a negative predictive value of 98% in both low and intermediate pretest probability. To be part of this assay, to have a successful assay, you not only need to have the sensitivity, but you have to, your test has to be highly reproducible as a quantitative assay, and it needs to be very validated against imaging methods, and it has to be validated in prospective outcome studies with a 3-month follow-up. So you can see that the VIDAS D-dimer, and these are 2 other assays, the other 2 assays quickly fall off. They both start out with a high negative predictive value, but you can see that only the VIDAS D-dimer stays upwards of close to 100% in the low risk, and continues to stay high through the intermediate risk. But so there are many patients under the yellow line that will fall into intermediate and low risk. But you can see that a lot of the patients that are currently being tested in this assay do not fall in the safe harbor here, and you cannot use it reliably as a rule out. So this is a little bit of a busy slide, but it shows you that this pool of people have low risk, have been stratified by, let's say, our Wells criteria as low risk. This is our intermediate risk, and this is our high risk group. And the low risk group have a 10% prevalence of thromboembolism in this group. The intermediate risk have a 30%, and the high risk have 70% of embolism. So when you look at this, the VIDAS D-dimer, the assay A for low risk, have a negative predictive value of 99.7%, and intermediate risk at 98.9%. So when you look at the low risk, there's only 1 patient out of that group that was done in the Krupp study that showed that that this patient had a false negative and actually did have a pulmonary embolism. However, when you dive into that study, that 1 patient who had the PE had neurosurgery 9 days prior and was short of breath for the past 3 days, and this patient was found to have a subsegmental pulmonary embolism. Now, in my mind, if I heard that history and got that physical on that patient, my gestalt would probably have said, this is a little bit more than a low-risk patient. And in fact, I probably would have, if the test came back negative as a false negative, I probably would have pursued it with further testing. You can see, though, for intermediate risk with the other assays, that automatically that the negative predictive value falls off sharply, and in none of the assays, including the D-dimer for high risk, because the prevalence of the amount of embolism that occurs in these groups are way too high to simply use the predictive rules and a D-dimer to rule them out. So D-dimers are not recommended for exclusion in the high-risk positive therapeutic predictive group. For every 2% decrease in sensitivity, 1 per 1,000 patient study will die of recurrent PE as a result of inappropriately withholding anticoagulant therapy. So that's the reason why it's extremely important that we find out, we stratify patients appropriately, take good histories, do good physicals, and couple that with high sensitivity and high specificity D-dimer to safely rule people out. So what is the cost effectiveness of this, of pulmonary embolism diagnosis and the impact that D-dimer has on them? Well, the analysis based on data from prospective outcome studies, exclusion by VIDAS D-dimer in patients with low and intermediate pre-test probability. To do a study testing with a helical CT plus or minus Doppler studies with high positive predictive values or positive D-dimer against age-incorporated analysis. The conclusions of this study showed that the diagnostic strategy with pretest probability and D-dimer is far less expensive compared with imaging alone. Well, that makes intuitive sense. The cost-sparing effect of D-dimer is reduced but not abolished with increasing age. As we stated previously on the slides, that age is a factor not only in getting false positives, but also in getting PEs. So we need to, for the future, look at the VIDAS D-dimer and somehow come up with age-adjusted charts so we are not imaging people that might have a false positive D-dimer just based on their age to be able to eliminate unnecessary testing in the elderly as well. This is another cost comparative analysis for pulmonary embolism. When you look at it, if you did 1,000 patients with suspected pulmonary embolism, which the prevalence in this group would have been 21%, if you did a clinical predictive rule by Wells criteria, the incidence, the N for low probability would be 600 out of the 1,000 or 60%. 10% of them would have pulmonary embolisms. The intermediate group would be another 300 patients, where that would be 30%, and 20% of that group would have pulmonary embolisms. And you can see that the high probability, and this is the reason why we don't want to use this protocol for high probability, that only constitutes 10% of the 1,000 patients or 100 patients, and a very high incidence of pulmonary embolism in that group. If we just did spiral CT on all comers, and let's just say it costs $400 a test for all imaging tests, that would come to $400,000. So, and when we look at, let's say, assay A and B, if we put them through the pretest probability for just for the low and intermediate patients, if we use a very high sensitive D-dimer, we would see that because there's going to be more false positives, we would have saved, that would have come to a cost of $287,000. If we used an assay that didn't have as good of a sensitivity and specificity, we would save a lot. We would save a lot more money because that would only cost $255,000. However, that would have missed 6 more cases of pulmonary embolism. So you need to get this sweet spot of the right clinical decision-making tool, making sure it's accurate, getting a high sensitivity and specificity D-dimer. It will save and eliminate a lot of unnecessary testing, and it will save money, not as much money as you would if you used a less sensitive and specific test, but that wouldn't be doing the right thing for the patient. So it's very important that you pick the right D-dimer in your institution. So why do I support the VIDAS D-dimer exclusion too? Because it's safe, it's cost effective, And it safely excludes VTE in outpatients. The intended use is for the safe exclusion only in low and intermediate pretest probability. It is CLEC compliant because it's found to be, I would call it 100% sensitive. And the cutoff for that is 500 nanograms per ml. It's a quick test. The rapid turnaround time for it is between 20 minutes and a half hour. Obviously a lot quicker than getting someone down to vascular lab or getting them into your scanner, especially if you want to screen their renal function before you do so. And it fits the criteria of CLEC because it has been extensively validated in outcome studies through the 7 prospective studies that looked at 6,000 patients of suspected PE. PE was excluded in 34 of these patients, which were low or intermediate, which had a low positive predictive value, probabilities and negative D-dimers. And it fulfilled the third criteria of CLEC, which was a 3-month follow-up in 2,166 of those patients, with a failure rate had a 99% negative predictive value. Something that we could ER doctors and providers can really wrap their heads around. And I think if you have joint decision-making, which is the vogue term right now, if you sit down with your patients and explain to them why you're doing what you're doing and what the risk and benefits are, especially in someone with an intermediate or low probability of having a VTE, I think patients are would be much happier if you follow the evidence-based guidelines. So what's this about the Choosing Wisely campaign? And I know this has been bandied about a little bit in the emergency medicine literature. Well, Choosing Wisely aims to promote conversations between physicians and their patients with this joint decision-making to help patients choose care that is supported by evidence, that is not that you're not duplicating other tests or procedures that they've already received, that you're increasing their free from harm in the way of radiation exposure, kidney failure, or cancer risk. But you are explaining to them, gee, you're at high risk, it's truly necessary you have the CT, or you're really at a very, very low risk, and I can safely do this quick test and discharge you that the pain in your leg is not from a DVT. And so there are many medical societies that have been asked to choose wisely by identifying the 5 tests, which I went over it initially at the beginning of the presentation that Harvard went through that exercise, and procedures commonly used in the field whose necessity should be questioned or probably changed. And VTE was one of those categories. It was number 2 that Harvard looked at. And there are 4 participating societies, medical societies, that were questioned this as well. And they now recommend performing the pretest clinical probability score and D-dimer before ordering a CAT scan for suspected PE. The 4 societies are the American College of Radiology, the American College of Physicians, the American College of Chest Physicians, and the American Thoracic Society. And you can see the website at the bottom if you wanted to peruse the Choosing Wisely campaign. So in summary, D-dimers in conjunction with a clinical prediction rule, you need to stick to a scoring system that integrates multiple clinical factors, including your own experience in clinical gestalt. You want to look at people's risk factors, their signs and symptoms, and you use your clinical judgment of the likeliness of an alternative diagnosis. It needs to be structured in a way to predict risk of having the DVT and PE by doing this pretest probability. The clinical pretest probability guides the diagnostic workup. Once you do your scoring, which provides an estimate of the pretest probability, those patients will fall into low, intermediate, or high risk. And you've got to understand that the prevalence of a thromboembolism in a low-risk patient is 10% or less, intermediate is 10 to 30%, and high-risk patients have a very high prevalence. And this protocol of doing CPR with a D-dimer is not truly indicated. And the commonly used validated CPRs are the Wells criteria, the Geneva score, or PERC. One bullet there's two bullets I haven't put on the slide, and those two are after you stratify patients into low, intermediate, or high risk, then you need to couple the patients that fall into the low and intermediate risk with a highly sensitive and specific D-dimer, and the only one that I'm aware of that follows the CLESI guidelines for a cutoff for negative predictive value would be the VIDAS D-dimer. And lastly, I think for research for the future, we do know that as you increase in age, there's an increased incidence of false positive D-dimers. So there needs to be further research to get us some tables to say, gee, age 50 to 55, the range maybe should be a little bit higher than 500. And as you go up in age, that the cutoff might be, might go up higher and higher. But that's for research and for another day. And I think if we can do that in the research, we can eliminate more and more unnecessary tests in the elderly. So I want to thank everyone for this participation. I think that this was a very timely topic. I think that the Choosing Wisely campaign, I know that I've adopted everything that Harvard is doing in their system, we've adapted here to our system. And I think the more that we think smartly about our patients and thoughtfully about our patients and create joint decision-making with our patients, the happier they'll be, the faster they'll be out of our ER, and the safer the discharge will be. So thank you very much for everyone's participation in this webinar.
Joseph, we actually have a couple questions already in, so if you'd like to begin those, I'll read the first one to you now.
Sure.
If patients have exposed ankle veins and slight increase in calf size and pitting edema, wouldn't DVT and cardiac workup be done?
Yeah, sure. I think, again, obviously bilateral disease is the odds of someone having a bilateral DVT is kind of more unlikely. You have to start thinking of that alternative diagnosis is the CHF. So if you start thinking more likely this is something other than DVT, then you should start, looking to work the person up for CHF or for stasis disease in the lower extremities. That's the whole point of the clinical decision making. But obviously, if you have someone that's been a stroke victim that has swollen lower legs that are painful, while they're being admitted, it wouldn't be bad if you're working them up for a DVT if they PERC out, or if they have a low if they go into a low or intermediate criteria to get a VIDAS D-dimer would give you that assurance that you're not dealing with the DVT.
And we have one more question. We were ready to purchase the Alere Meter Pro for D-dimer. Are you able to comment on using the VIDAS assay over this option and why?
I'm not familiar with that particular device. It sounds like it's a point of care testing. I don't know. I think you would really need to look again at the sensitivity and the specificity and to look back into the research that was done on it to make sure that it fulfills the CLEC definition of a good negative predictive value for a DVT or PE.
All right. Thank you, everyone, again for your participation and for listening. At this point, if there are any more questions, they will be given to the speaker and addressed later on. Look for an email within a few days with the archived video, and you can view and share with coworkers that might benefit from the information. Again, if you have questions, you may email events@advancedweb.com. And thank you to our sponsor, bioMérieux, and our speaker today, Joseph Feldman. And thank you for everyone who has attended. Have a good day.